Okay. Shall we start?
Yes, please. Go ahead.
Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Welcome, everyone, and thank you for joining us today for this special webinar hosted by Imamia Medics International IMI UK chapter in collaboration with Sadiq International Virtual University, SIVU. For those who may not be familiar, Imamia Medics International is a global network of medical professionals committed to enhancing healthcare delivery and education through collaborative efforts. It provides a platform for medical professionals to share knowledge and expertise, advancing healthcare practices around the world. IMI UK chapter is particularly focused on educational outreach, offering workshops and webinars that bring together thousands of participants from across the globe. Sadiq International Virtual University, SIVU, was founded by Dr. Shabeeh, a unique initiative that brings together experts in various fields of medicine and healthcare to create accessible online learning experiences. SIVU organizes a series of international workshops and webinars designed to educate, inform, and inspire healthcare professionals. This platform connects learners and experts from around the world, making it possible for us all to benefit from the knowledge shared. Today's session, Management of Diabetes in Ramadan, is a crucial and timely topic, especially as Ramadan is here. We are incredibly honored to have Dr. Fareeha Rizvi with us today. Dr. Rizvi is a consultant physician at Barts Health NHS Trust, specializing in diabetes and endocrinology. With her vast experience, she has been dedicated to diabetes reversal and improving patient outcome. Dr. Rizvi holds an MBBS, MRCP, and MSc, and she's also a TV host on Islam Channel. You can follow her on the Instagram on the webinars poster, where she offers valuable health advice. Her role as a health coach, social media personality, and international distributor for the Feel Great system underscores her commitment to empowering individuals to take control of their health. We are truly excited to hear from her today. Before we begin, I would like to introduce myself. I'm Dr. Qurat, a member of the Educational Webinar Coordination Team here at IMI. I also coordinate the dental wing and have previously served as an honorary clinical teacher in primary dental care at King's College London. It's an honor to be here with you all today. Without further delay, it's my pleasure to hand over to Dr. Fareeha Rizvi, who will guide us through today's webinar on managing diabetes during Ramadan. Dr. Rizvi, the floor is yours.
Thank you so much, Qurat. Assalamu alaikum, everyone. Ramadan Mubarak. Thank you for joining on this beautiful day in London whilst you're all fasting. Thank you so much to IMI UK and SIVU for this invitation. So we'll start. We have a big topic to cover, and I'm happy to take any questions or queries that you have at the end. The aim of this webinar is to spread knowledge and improve awareness around the management of diabetes. We'll discuss both type 1 and type 2 diabetes. So we have some learning objectives. And as I mentioned, the purpose of this educational session is to update healthcare professionals and also individuals living with diabetes who plan to fast. We will cover how best to advise patients on whether they should undertake fasting during Ramadan, how to conduct a pre-Ramadan assessment, specifically related to medications, and our aim is ultimately to reduce the incidence of diabetes emergencies, so hypoglycemia and DKA in particular, and to give a practical approach to patient care. We have a few cases as well that we'll discuss. So why is diabetes important? I often joke to my trainee doctors that general medicine is the most important thing in the world. We've all lived through a global pandemic. COVID essentially was a general medical condition, and general medicine is a footnote to diabetes. So whoever practices diabetes, whoever is an expert in diabetes is an expert in general internal medicine, which is the most important thing in the world. And this World Atlas really signifies and shows the example of how diabetes is becoming a global emergency. So this is the IDF, International Diabetes Federation Diabetes Atlas. It's freely available online. If you Google it, it comes up. And this shows the incidence of diabetes, which is set to rise from 2021 to 2045. So over kind of 20, 25 years, you can see that it is absolutely terrifying that on every continent on planet Earth, the number of people living with diabetes is set to rise. And what I am most concerned about is that it is rising in the lower income countries. So if you see Africa, here, the Middle East and North Africa, the MENA region, 87% increase. I mean, this is absolutely terrifying and staggering numbers. And, you know, the healthcare systems in the West are not able to cope with the surge in diabetes and obesity, and also the incidence of type 1 diabetes is also increasing, let alone the healthcare systems and structures in the lower income countries. And why is this important? Well, of course, we demonstrated that diabetes is rising, but it is rising disproportionately in areas where there are more Muslim people. So the MENA region, as we discussed, and also the South Asia Pacific region. So by 2050, 53% of the global Muslims in the world are expected to live in South Asia, and 20% are projected to live in the MENA region. So, you know, Muslims are increasing. Islam is the fastest spreading religion in the world, and diabetes is increasing. So this is of immediate concern to everyone, not just healthcare professionals. It's important for people who are planning health economics, who are planning government policy. All of these things need to be taken into account. So in the UK, where most of us are from today, there's around 4 million Muslims living in the UK, making up about 6.5% of the population. So understanding Ramadan, I'm sure everyone on this call knows what Ramadan is, but obviously I do have to explain it in some detail when I'm giving this talk to other colleagues. I gave this talk to my acute medicine colleagues and the Division of Medicine earlier this week. I do a training session like this every year, and I do have to explain what Ramadan is. And we all know it comes as part of the lunar calendar and is 10 to 11 days earlier every year, which means that every year the duration of fast is slightly different. And who should fast? All healthy Muslims who have reached puberty, women who are pregnant or lactating, or people who are traveling, they are exempt. I do a pregnancy antenatal clinic, a pregnancy endocrine and diabetes clinic, and you would be surprised as to how many pregnant women in my clinic are actually fasting. Genuinely, women with diabetes who are on insulin have been fasting in my clinic, and I have to remind them what is important for their health. We'll discuss here the EPIDR study as well, which is a really important seminal, really landmark study, one of the earliest studies in diabetes. We'll discuss that. So what is the physiology of fasting in normal subjects? So what happens to glucose in people who are fasting? So in Ramadan, non-diabetics do see a slight reduction in their mean glucose levels. There is a slight reduction in insulin resistance, and this is probably why average glucose levels drop a little bit. Some people do experience some weight loss, 1 to 2% weight loss, but there is some evidence that this weight loss is perhaps more water weight. So this is really important. You know, a month is not very long, but it is long enough to see some early physiological changes. Effects on body weight, time-restricted eating, which is what Ramadan fasting is essentially, has now been scientifically proven to have very important metabolic benefits. And as we've discussed, there is some evidence that there is weight gain. Whether that weight gain is just water weight, as we've said, or whether it is actual body fat, probably depends on each individual. Changing in sleeping patterns. This is really important, and we have another slide discussing this, but there can be, you know, very disrupted sleep in Ramadan, and this can have a knock-on effect on energy levels later in the day. This does also have a significant effect on your diurnal hormones, so particularly cortisol. Your normal cortisol diurnal variation is significantly disrupted in Ramadan, which does improve towards the end of the month. But that, you know, the disruption in cortisol can really also affect energy levels, as we've said, but also hunger. When you have disturbed sleep, the hormones that are affected the most are insulin, cortisol, ghrelin, and leptin. So these 4 hormones, and also growth hormone, 5 hormones are really significantly disrupted when we have poor sleep. So we also experience less deep sleep. So REM sleep, which is like stage 3, stage 4 deep sleep, the refreshing sleep, that is often interrupted. I'm sure all of us, when we wake up at suhoor and the alarm goes off, and then we realize that we're actually in our deepest phase of sleep, often dream sleep. So when that happens, that can have a knock-on effect on the rest of your hormones. And we know from evidence that people that tend to work night shifts or people that have very disturbed sleep, there is a long-term risk of long-term increased risk of dysglycemia and type 2 diabetes in people that work shifts or have disturbed sleeping patterns. So what happens in people with diabetes when they're fasting? So I'm sure you all remember this from medical or nursing school or university. What happens when you fast? Well, ketogenesis is something that occurs when you are breaking down fat. So after you have depleted your glycogen stores from your liver, if the fast is long enough and the glycogen stores have truly been depleted, then you will start to break down fat, which is ketogenesis, and that is used as a substrate for peripheral tissues and also for gluconeogenesis. But what happens in patients with type 1 diabetes? So this is something that we have to be very mindful of, that they have a lower threshold for ketogenesis because of absolute insulin deficiency, and we want to avoid ketoacidosis. So there is a difference between ketogenesis and ketoacidosis. And ketoacidosis is a very dangerous disease state, which we see in type 1 diabetics. We can also see it in patients with type 2 diabetes, particularly those that are on SGLT2 inhibitors. And there is also a behavioral aspect and a hedonic aspect of eating and appetite regulation. So we may just, you know, consider that we need to eat for our energy levels. We need to eat to keep full, but actually there's a hedonic and enjoyable aspect of eating. Some patients experience satiety at lower calorie intakes. Other patients achieve satiety at higher calorific or carbohydrate intake. So everyone is slightly different. And there's lots of different complex aspects that control appetite and calorie intake. So the hierarchy of satiety, what is the most satiating macronutrient? So the macronutrients are protein, carbohydrates, and fat. Alcohol does also count as a macronutrient, but obviously it is not relevant to our discussion here. Protein, gram per gram, protein is the most satiating macronutrient. 70% of all calories consumed worldwide are carbohydrates. And I think this is where we tend to get things wrong. And we can discuss that. This is a whole separate discussion. But where we are opening our fast and at suhoor and at iftar, both times, we do need to prioritize protein. So calories in Ramadan and hunger. This was an interesting study done in Reading in the 1990s. Small group of men and women, kind of 15 men, 15 women, and they self-reported their hunger during Ramadan. So the dark blue line there is day 3 of Ramadan, and the lighter blue line is day 24. And as you can see, females reported increased hunger no matter when it was. So even later in the fast, later in the month, they were still hungry, hungrier than men. And I mentioned this is a slightly old study. The reference is there at the bottom. The only thing I would say when I read this study is it's a little bit sexist. It suggests that women in this study tended to be at home all day. They didn't work, and so they were constantly surrounded by food and were involved in preparing food, and that's why they were more hungry. So there isn't really a physiological explanation for this yet, but I'm sure there is a hormonal explanation for this. And this is a CGM, so a continuous glucose monitoring profile for people who are healthy, so non-diabetics, and what happens to their glucose excursion. You can see there the red line is when we open our fast. At iftar, there is a significant glucose excursion. So what happens in patients with diabetes that wear CGM? The same thing happens, although there may be an element where their blood sugar drops slightly before iftar. And then there's a more significant glucose excursion. So I hope we can all appreciate that. I obviously look at CGMs multiple times a day, but CGMs really can be interpreted to a degree by most people, as long as you look at enough CGMs. But I'm sure any, even a layperson can appreciate the glucose rise there at iftar. So hypoglycemia, these are two really important studies. EPIDR is a study of patients with both type 1 and type 2 diabetes. And there was significantly more episodes of hypoglycemia during Ramadan in patients with both type 1 and type 2 diabetes. And that was more common in patients with type 2 diabetes who are using insulin. CREED is a study of just people with type 2 diabetes. And again, there's an increased risk of hypoglycemia before and during Ramadan in patients with type 2 diabetes. Hyperglycemia, so the same study, EPIDR, showed that there's a significantly increased risk in severe hyperglycemia and also ketoacidosis. So this is something that we need to really counsel our patients about. Benghazi diabetes and endocrine study, a smaller study, but showed similar correlation with insulin treatment and increased risk of hypoglycemia. And just for people that don't deal with diabetes very often, severe hyperglycemia would be, something with a blood sugar of kind of above 25 millimoles. The Oman police force also showed more hypoglycemia with patients with type 2 diabetes. So what are the risk factors of DKA or diabetic ketoacidosis? So diabetic ketoacidosis is a medical emergency. It has three main physiological abnormalities. The first is diabetic, so hyperglycemia, high blood sugar, ketones, which we measure with a finger stick or urine, and acidosis, so acidemia. These three things are diagnostic of diabetic ketoacidosis. And like I said, this is a medical emergency that requires emergency medical treatment in a hospital. And there is a significant morbidity and mortality associated with DKA. So the risk factors are somebody who tends to be hyperglycemic, who tends to run high blood sugars before Ramadan, an individual with type 1 diabetes who has adjusted their insulin doses without kind of proper guidance, increased viscosity, blood viscosity due to dehydration. So when we had very long fasts in the very hot weather, that is also a risk factor for DKA. Somebody that already has established or advanced micro or macrovascular complications, so things like retinopathy, neuropathy, nephropathy, cardiovascular disease, that sort of thing. If you have this in your patient, you need to counsel them about the risk of DKA. And renal insufficiency on its own is an independent risk factor for DKA, and it's something I see a lot in hospital. Dehydration and thrombosis, there is some evidence that the dehydration that occurs in Ramadan when fasting can actually lead to an increase in both arterial and venous thrombosis. So that's very interesting. We need to counsel our patients about this. This again may be more relevant when the fasts come in hotter months, in the longer months, but anyone that has risk factors, we need to counsel them. So we'll talk about risk stratification. This is something that is not happening enough in primary or secondary care or in the community. And I think it's so important that people like yourselves are on the call here today so you can disseminate this information into your own day-to-day practice. So we've discussed some of the risks associated with fasting in diabetes. There's a risk of severe hypoglycemia. So severe hypoglycemia, again, to define that, that is a universally accepted definition. A severe hypoglycemia is that which requires third-party intervention. So an individual that's experiencing hypoglycemia, most of the time they can act on it themselves. They will have, hopefully, some hypoglycemic awareness, and they can act on treating their hypo before it becomes severe. Severe is when a third party has to step in. So a relative, a bypasser, and or an ambulance needs to be called. So that is a severe hypoglycemia, and that can occur in both type 1 and type 2 diabetes. We've talked about the EPDR study and the CREED study. We've talked about thrombosis, hypoglycemia, and also retinal vein occlusion is also a real risk with fasting in diabetics. So this is the risk calculator tool, which has been adopted by lots of different international governing, bodies and diabetes societies. So the IDF we've mentioned, you saw their atlas earlier. The IDF have their own guidelines. So the South Asian Health Foundation, which I am a member of, they also have guidelines, and the ADA and the EASD adopted these guidelines in 2020. And they're very simple, very straightforward. You can choose either one of these. They're all validated to be used in diabetes. I prefer the IDF one, that's what I use. And you can see here on your screen that there's a risk element, so 1, 2, 3, 4, 5, all the way up to 14, sorry, and you categorize the individual, the patient sat before you, and you go through their diabetes, so whether they have type 1 or type 2, how long they've had it for, if they've ever had a hypo or a severe hypo, what is their glycemic control like, what is the treatment that they take, have they got complications, have they got renal disease, are they pregnant, are they frail, do they participate in physical labor? What have they done in previous Ramadans? That's a really easy question you can ask. Well, what have you done before? And how long the fast is. And then you end up with a risk score. So 0 to 3 is low risk, 3.5 to 6 is moderate risk, greater than 6 is high risk. And it's similar for the other societies here. So this is the IDF practical guideline. Again, it's freely available on Google. If you're interested in this, I would highly recommend this guideline to you. It's a bit long, it's about 100 pages long, but they have really interesting references broken down into a lot of detail. And this is the IDF guidelines that we've kind of discussed already. So this is quite self-explanatory, and it's quite an easy system that you can show your patients as well. I think patients quite like this because it simplifies it. So moving on to some cases now. So this is Ahmed. He's 50. He works as a security guard. He works night shifts and is constantly snacking. He's been diabetic for 5 years. He has type 2 diabetes. He also has high blood pressure and cardiovascular disease. His A1C is not that bad, 53 or 7%. He's slightly overweight. He's got normal renal function. His metformin, his therapy is metformin, gliclazide, and ramipril. So what do you think he scores as? I know we don't have time, but if you want to put in the chat, do you think he's low risk, moderate risk, or high risk? What do you guys think? There's plenty of Ahmeds walking around in East London. If I look out of the window, I can see plenty of Ahmeds. I'm sure we all know an Ahmed if we are not an Ahmed ourselves. So he is actually low risk, believe it or not. So yeah, he's not high risk. Sorry, let me just go back to my page. When I first did this, I also thought he might be high risk. He's not. He's actually low risk. So how do we counsel him? So we can counsel him based on these guidelines. Actually, his type 2 diabetes is not that poorly controlled. His A1C was quite good. So fasting actually may benefit him, but we do need to adjust his medications, and we'll come on to that. So this is Shazia. Shazia is 46. She has a BMI of 31. Her A1C also is not bad. It's better than Ahmed's. Her cholesterol is a bit high, but she does have a reduced GFR. She has a strong family history of type 2 diabetes, and both of her parents have had serious complications with cardiovascular disease and diabetes. She has not contacted her GP actually about her intention to fast, and this is something we can perhaps discuss as well. How many of you guys are having patients approach you asking about fasting? So those are her medications. Shazia is on metformin, glycoside, ramipril, and simvastatin. Is she low risk, moderate risk, or high risk? What do you guys think? So I'll give you a second to answer. Shazia is actually high risk. So the reason is because of her reduced GFI. So she has an increased risk of, worse dehydration. And also when you have a CKD or reduced GFR like that, you are at increased risk of dysglycemia. So having hyper or hypoglycemia, both is possible when you have a reduced GFR like that. So we should ideally counsel Shazia against fasting. So we've discussed the risk stratification. You need to have an individualized approach for each of your patients. This shouldn't take long. The risk stratification should not take long. It should, take less than 5 minutes, really. Counseling the patient for, another few minutes. So it is possible in a short appointment time. And the purpose of today's webinar is to increase awareness, and you can count this as a training as to what to do with your patients. We do advise that you counsel your patients a couple of months before Ramadan. If patients haven't had blood tests, then a couple of months before is a good time to get blood tests. So you can get that, GFR, you can get that A1C, and you can sit down with the patient and talk to them, or call them and talk to them about their risk of fasting. Okay, so patient education is super important. We have to empower patients to make the correct choices. If somebody, for example, has a history of hypoglycemia, then we can perhaps address that at their pre-Ramadan risk assessment. There are some education programs out there that you can refer your patients to. The references are there. Some patients are super motivated, and we should really encourage those patients to find out more about diabetes, Ramadan, and fasting, and how it might affect them. So sermons in the mosques and the media, I try my best. I have a Ramadan radio series that goes out every year. It's in Urdu, it's on the local radio station, but we do need to do more. So I think webinars like this really help, but we do need to reach the average person on the ground. So somebody who hasn't seen their doctor for a while, that sort of person who may have an intention to fast, how do we target those people? Blood glucose monitoring has been a contentious issue in the past with regards to diabetes and Ramadan. Some people still are worried that a finger prick glucose check may invalidate their fast. That is not true. And in the IDF 100-page guideline, it is clearly outlined on there from many different schools of Islam that doing a finger prick blood glucose check does not invalidate your fast. And we will discuss when you should be telling your patients to use the blood glucose monitor. There's a nice picture later on when you should be telling patients to check their blood glucose. When should we be telling our patients to break a fast? Well, if there is a diabetic emergency, so hypoglycemia, severe dehydration, or hyperglycemia, you need to warn your patients about this before they actually start fasting. Because a lot of patients will resist breaking their fast. Again, I'm sure you've all encountered patients like this. So we've kind of discussed this again. This explains it in a little bit more detail. If your patient wants, definite blood glucose readings of when they should break their fast, then they are there for you. A hypoglycemia, we define it of a blood sugar of less than 3.9. I'm happy with a blood sugar of 3.9 to 4. Some people may consider 3.9 a bit low, actually, and a blood sugar greater than 16. If they have type 1 diabetes, or if they're type 2 on an SGLT2 inhibitor, some patients will, who are type 2 on an SGLT2, will have ketone meters. You do also want to get somebody with hyperglycemia to check their blood ketones at the same time. Okay, so this is a summary of what we've discussed. assessment, risk stratification, and then the advice you're going to give your patients. So when should patients be monitoring their blood glucose themselves? There's a 7-point guide for Ramadan, and it explains it again very nicely. So pre-sahur, when they wake up, after, if they've gone back to sleep, midday, mid-afternoon, pre-iftar, 2 hours after iftar, and any other time when they feel unwell. Of course, patients are not going to check 7 times a day. You know, we won't have enough glucose testing strips for patients in Ramadan either. Some patients will be on a CGM device, but you know, practically you can tell the patient to check over the course of a few days. So if they can do it, you know, maybe 1, 5, and 6 on Monday, and then 2, 3, and 7 on Tuesday, they can vary it a bit, as long as they're not on insulin. If they're on insulin, then it's slightly different. Again, we've discussed this already. Symptoms of hypoglycemia, you should be asking your patient if they have hypoglycemic awareness. This is very important in patients with type 1 who have had a longer duration of diabetes. Yeah, you have to ask them if they're hypo aware or unaware. There's something called the GOLD score. We should be documenting the GOLD score for patients with type 1 diabetes. And similarly, symptoms of hyperglycemia. And these symptoms can be, you know, very subtle, and they can come on slowly and then suddenly accelerate. So each person should be aware of what their symptoms are. Some of the symptoms are quite non-specific, and you need to explore with your patients how they treat hypo. That's super important, because I come across patients who treat hypoglycemia in all sorts of different ways. And there are standardized ways of how to treat hypoglycemia. Generally, I prefer juice. So a 200 ml carton of juice that has between 10 to 20 grams of carbohydrate, some is around 15 grams of carbohydrate. They should be using juice, ideally. Some patients use jelly babies. You should never use chocolate, milk, never use those things. It should be juice or jelly babies, and they should be checking their blood glucose every 15 minutes after a hypo treatment. Exercise. Patients are generally not recommended to do rigorous exercise, but, you know, a walk, meditation, gentle yoga, that sort of thing is perfectly acceptable. And a nutrition plan. For those of you that know me, you will know that I'm absolutely obsessed with nutrition. We'll come on to discuss nutrition separately and what a healthy Ramadan plate should look like. But you should be giving your patients some basic advice of avoiding very sugary desserts, very sugary, you know, juice, sherbet, that sort of thing. And this is the healthy Ramadan plate, and I have a slight issue with that. I think it's probably got too much carbohydrate on there and probably not enough protein. But sometimes patients actually are very receptive to you showing them this sort of thing. So we've discussed meal planning, fluid intake. You can't really give people a fluid prescription. Our body has evolved with very sophisticated osmoreceptors and osmostats, and our thirst is the best indicator of our fluid requirements. Don't, you know, you can tell patients to aim for 2 or 3 liters, but it really depends on each individual. And medication adjustments, I know this will be something that everyone's very interested in. What do you practically do with the patient sat in front of you? And again, this is taken from the IDF guidelines, and it breaks down each of the type 2 diabetic medications. Interestingly, the SGLT2s and the GLP-1 analogs do not require a dose adjustment. Metformin, generally speaking, doesn't require a dose adjustment, neither do the thiazolidine diones. But where you might run into issues are the sulfonylureas, which they do suggest that you have a dose adjustment. For insulin, again, there is lots of different ways you can adjust insulin. Patients should be adjusting insulin themselves. They should be feeling empowered to do that. I often tell my colleagues and junior doctors who I train that insulin therapy is hocus pocus. It's just, you know, it's a little bit of a dark art, and it just comes to you with time. And often patients know what insulin works for them as well. But this is kind of the basic skeleton of advice you can give patients, but all management should be individualized. So we've discussed this. Mycotic fungal infections we haven't actually mentioned. These are more common in patients on SGLT2 inhibitors. They are common in people with poorly controlled diabetes themselves. And euglycemic diabetic ketoacidosis is also a significant, very severe risk of those patients with type 2 diabetes who are on SGLT2 inhibitors. So dapagliflozin, empagliflozin, canagliflozin, those are the three most commonly prescribed. Practical tips we've discussed. I hope this is clear. I hope you feel empowered to go and look up these resources yourself for your own patients. Sick day rules as well. We need to mention sick day rules. This slide is slightly old. I used it during the COVID pandemic, but there are still principles there about what to do when a person is ill with diabetes. We've mentioned checking blood glucose, and we've mentioned checking ketones in patients with type 1 and those with type 2 diabetes taking SGLT2 inhibitors. So post-Ramadan review in a utopian world with unlimited NHS resources and unlimited appointments, we would be bringing these patients back to see them in a post-Ramadan review, face-to-face or telephone clinic, and ask them how it went. So ask them if they had any diabetic emergencies, what their experience was like, how did they self-manage their blood, how did they self-monitor their blood glucose, and how did they self-manage their medications or insulin. So that's a summary. I had to whiz through that very quickly. I have another section. If anyone's got any questions or queries, I'm happy to take questions now. But I have another small section on diabetes and technology, which I think will be really interesting.
Yes, Dr. Fareeha Rizvi, are you done with your lecture?
No, we have another section on diabetes and technology, which I'll carry on for another 5
minutes. Please, go ahead.
That's okay?
Yes, let's finish it and then.
Okay, and then if anyone's got any questions, please feel free to ask. Okay.
Yes.
So no questions, so I'll move on.
Yes, you go ahead and we'll answer the questions in the last 15 minutes.
I have another section. It seems to have disappeared. Here it is, sorry. Okay. All right. Sorry, I don't know why that happened.
No worries.
It's a bit of a long presentation, so it does. No, I don't know why it's doing that here. Sorry. Maybe I'll share my slides like this. You can still see them. So diabetes and Ramadan. Can you see that? Yeah?
Yes, we can see this.
All right. So I'm sure, again, a lot of you have come across the management of diabetes with different types of tech. But technology in diabetes is not a new thing. Insulin was discovered just over 100 years ago. In the 1970s, the first home glucose testing kit was available. And insulin pumps have been around since the 1990s. We first got our commercially available CGM after 2010. We started to use it in clinical practice, and it was approved by NICE in 2017. And this is an update of NHS practice with regards to diabetes. Now, this is specific to type 1 diabetes, but we are using glucose monitors and CGM in patients with type 2 as well. So as you can see, over the last kind of 8 years, there has been a real increase in diabetes tech. It really is a new era of diabetes management. And every few months, we are getting updates in the technology. The sensors that we are using are becoming more and more accurate. And I do, as I mentioned, a pregnant type 1 diabetes antenatal clinic, and I'm using all sorts of technology in that, which is really satisfying, and it can be absolutely life-changing for patients of all ages. I used to do a joint pediatric clinic. I don't do that anymore, but when you have toddlers, 3-year-olds with diabetes, and they're using diabetes technology, the amount of peace of mind it can give to parents and carers really is extraordinary. This was not available just a few years ago. So with these technologies, we do interpret the blood sugar a bit differently. You may have heard of time in range, and that we use it will supersede A1C in the future, because as you see, an HbA1c, you can have an HbA1c of 7, but have a lot of variation in your blood glucose. as you can see, by 1, 2, and 3. And what we want is patients to be in the green zone for as long as possible. And that is your, pie chart here with the number 3. But A1C of 7% can represent any of these glucose profiles. So personal CGM, there is real-time CGM, which is mainly Dexcom, but also Freestyle Libre had a software update in July 2023. Previously, Freestyle Libre was intermittently scanned, so the individual actually had to scan it, but now you get a continuous glucose profile on Freestyle Libre as well. And I'm sure you're all aware of these. They have excellent marketing arms, both of these companies. They're vying for everyone's business. And there has been a general increase in the use of smart technology. CGM is great. There are other things. There's different apps. There's smart weighing scales, smart socks, which I haven't come across, smart blood pressure monitors, and obviously smart watches. So some of your patients will be using some of these or all of these, in fact. So how can glucose sensing technology help? How can it help us in Ramadan? Well, it can help a lot. I have plenty of type 1 diabetics on pumps who fast successfully in Ramadan. So I've seen it. I look after patients who do it, and it really is game-changing. So again, if you've risk stratified a patient and they don't have cardiovascular disease or diabetic complications or CKD, then a type 1 diabetic could feasibly fast in Ramadan. What I like in particular, as it mentions here, is this behavior modification. So particularly patients with type 2 that don't have good control or who have, not the best diet and lifestyle, if they wear a CGM, then it can allow for micro learnings. And people see, well, this plate of biryani or these pakoras or samosas did this to my blood sugar, and it can lead to micro learning in the correct motivated individual. We've talked about the effect of Ramadan on CGM profiles. We talked about this earlier. And what do the arrows mean? So often with the app, the CGM app, there will be arrows. So it will say blood sugar of 7, and there'll be an up arrow, a down arrow. Well, the arrows actually mean something, and we need to educate our patients about this because it refers to the rate of change of glucose. And this may inform when a patient actually might treat a hypo or hyperglycemic episode, or whether if they're wearing a pump, whether they give themselves a correction dose, or whether they give themselves a manual injection as a correction dose. So this kind of explains that a bit in a bit more kind of an obvious way. This will be what the patient will see on their screen. And this is after a hypoglycemic episode where a patient has treated it and their glucose is rising rapidly. And this is the advice that we give our patients on how to avoid hypoglycemia. If they are on a hybrid closed loop artificial pancreas pump, then the treatment for a hypo is a little bit different, and that will be advised by the specialist. And when should patients use the Libre? Well, this is the advice you're going to give them. It's similar to what we mentioned earlier about the self-monitoring of blood glucose. How often should they be looking at their Libre? And if they're on insulin, they need to bolus before a meal. And this is to take their Humalog, Novorapid, or quick-acting insulin injection before they are due to open their fast. Type 1 diabetics will carbohydrate count, so they will bolus. The number of units they will inject will be proportionate to the amount of carbohydrates they eat. But as you know, in Ramadan, iftar is a feast. It's a fast and a feast that we experience in Ramadan. And often, sorry, I've got a dry throat because I'm fasting, sorry. Often what happens is you and I, and also patients with diabetes, will be eating, and snacking all night. And that can be quite difficult to manage, and that can be difficult to carbohydrate count for. And this is, again, something that we need to talk to our patients about. Fat and protein mixed in with a meal will absolutely affect the glucose profile. So if you have pure carbohydrates, then your blood glucose excursion will be very different. If you have, say, something like a cheese pizza that has some protein and fat in it, as well as carbohydrate, then there will be a slower, longer release of the carbohydrate. It will be digested slower, and the glucose rise will be, it will be slower to rise, it will be up, the glucose will be up for longer, and it will be slower to go down as the fat and protein is digested. So this sort of glucose profile is quite difficult to manage. And as you can see here in the bottom graph, when patients are on closed loop insulin, so a closed loop pump, then there will be much more insulin delivery. I think my throat has given up now. Any questions? That's the end.
Thank you so much. It was so informative. Thank you, Dr. Fareeha Rizvi, for that excellent informative lecture on managing diabetes during Ramadan. Honestly, we truly appreciate your insights and practical advice. Just to note down in a nutshell, like a little quick summary of key points from today's session were when to break your fast, which said that always check symptoms of hypoglycemia, hyperglycemia before deciding to break your fast. Then you mentioned poor sleep, and you discussed the 5 hormones that affect the sleep: cortisol, insulin, leptin, growth hormone, and their impact on diabetes, and ghrelin. How fasting affects patients. You explained the physiological effects of fasting, including blood sugar and insulin sensitivity changes, behavioral appetite control. You emphasized managing appetite and behavior to help control the blood sugar during fasting. You prioritize the proteins, encourage protein-rich foods to maintain muscle mass and help manage hunger and blood sugar levels over carbohydrates. Also, risk of diabetic ketoacidosis. You highlighted the importance of awareness about the risk of diabetic ketoacidosis during fasting. Then you mentioned risk of hypoglycemia and hyperglycemia, discussed how fasting increases the risk of both conditions and how to mitigate them. Risk stratification for fasting. You recommended evaluating patients' individual risk before deciding if they can safely fast. Then those 2 case studies were amazing. We reviewed different case studies to better understand the management during Ramadan. Patient education is very important from a doctor's perspective, in emphasizing the importance of counseling patients about the risk of fasting and pre-Ramadan risk assessments. Then you mentioned principles of diabetes care, focusing on ongoing care principles during fasting, especially managing blood glucose levels. Monitoring the blood glucose levels, you suggested checking the blood glucose at key times before sahur, before iftar, and 2 hours after iftar, and so on. All of this will be on the YouTube channel of SIVU series of webinars, so everyone can take a look again to know more about it. Exercise, reminded not to engage in strenuous exercise during fasting, but instead gentle activities. Healthy Ramadan plate was exceptional to know, introducing the concept of balanced nutrition in Ramadan, emphasizing healthy plate in appropriate portions of protein, carbohydrates, and vegetables. That's in a nutshell. And Dr. Rizvi's Ramadan radio series is something to be followed if you're interested to know about diabetes more. Great to hear about Dr. Rizvi's Islam channel presentations as well. So you can go on Islam channel. If you can let us know in the Q&A session when they can see these. And be sure to follow her on fareeharizvi.com on her website, and Instagram is @diabetescare with Dr. F. Rizvi. It will be on the chat group and also on the SIVU webinar series, which all the links are attached on the chat section, so you can follow those. And once again, thank you, Dr. Rizvi, for sharing your expertise with us today. We now welcome any questions from our participants. So far, we have 2 questions that I have jotted down. Number 1, Dr. Rizvi, is what is the reason of the rise in diabetes in low-income countries? Is it increased detection or population growth, or a change in lifestyle, or increased availability of high-density foods, or all of it? That was your first.
All of the above. That's an excellent question. So, the rapid urbanization that we have experienced in certain parts of the world, in the lower income countries, this is a whole talk in itself, which I do give a talk around this. But, in my lifetime, I can remember in, for example, Pakistan, there was no McDonald's, there was no Burger King or KFC. And in a lifetime, the eating habits have changed from whole foods, relatively low, so no processed foods. Our ancestors, even a couple of generations ago, used to eat only whole foods, whole grains, high fiber, more vegetables, lentils, so more of a vegetarian diet with occasional meat. They certainly didn't used to have meat every day, and no juice, basically water. And they used to walk everywhere, and a lot of them were agriculturalists or used to cycle to places. Now, within a generation, we have gone from that to ultra-processed food, consuming far more animal products than we should be consuming. We do need to eat a certain amount of protein from animal sources, but not as much as we do. And the increase in saturated fat intake and animal product intake has contributed a lot to insulin resistance. So there's that, and you know, these big companies that make this sort of food have neuroscientists on their board of advisors. So, for example, I do a diabetes reversal retreat, and somebody mentioned that one of the dietitian colleagues who was working with me explained that Doritos before it is a new flavor of Doritos is released to the public, a neuroscientist consults on the crunch, the flavor, and you know, the general mouthfeel and the dopamine release that occurs when you eat these sorts of foods. So there's a double whammy of an increase in big food that people are consuming and moving away from whole foods. And also a lot of these foods are addictive. It is a little bit, what's the word? Whether food addiction truly exists is yet to be defined. But, you know, the big companies make food that change people's eating habits, and then they bring out the drugs to help us lose weight. So everyone is profiting off of people, and this is hypercapitalism. This is the world that we live in.
Excellent.
It's boring to eat broccoli, isn't it? It's boring to eat broccoli. It doesn't give you the same dopamine hit. It's boring to eat dal. And that is the world that we're living in.
And second question, Dr. Rizvi, is in South Asian diabetics, could you please comment on what is the impact of traditional iftar delicacies such as samosas, ruafza, and pakoras after a full day of fasting?
Yeah. So the worst thing that you can do as a South Asian person is to consume these things on an empty stomach. So if you are going to have sharbat or pakora or samosa, then please line your gut with some fiber first. Always have fiber first. What is very dangerous is on a completely empty stomach, we have this huge intake of carbohydrate, and the glucose excursion that results from that is, you know, really extraordinary. So if you're going to eat these foods, I would always suggest that you eat a green salad first. So you have, you know, just a salad with lettuce, spinach, have a few different types of green vegetables in your salad. Have some peppers or radishes, cucumber, and have that first. That will line your gut with fiber, and then it will also help you eat a bit less of these things. I'm not saying you can't eat these kinds of, you know, historical traditional foods, but you need to do it the right way.
Perfect. That's it. Any other questions? I guess it was very self-explanatory, and everyone, you know, understood it very easily. If there are any other questions, please do feel free to.
Can I ask the question, Professor Bukhari?
Yes, please, go ahead.
Thank you very much. First of all, I am highly obliged and thankful that you have given a very beautiful lecture and awareness, because the diabetes is not only the disease of the world, but it is becoming pandemic in Pakistan. If you say out of 25 crores, almost 3.3 billion people, 30 million people are suffering with this.
And many more undiagnosed.
If you say, what is the reason that suppose in 2024, 25, 23, 23, why this diabetes is becoming more prevalent in female as compared to the male in Pakistan?
Yeah. So I actually wrote a paper for the Dow.
Female, especially, because no doubt the number of diabetic patients are low, but anyhow, if we say prevalence, why I think it's more increasing in the female.
In females, yeah. Again, so I wrote a paper about this a couple of months ago for the Dow College of Medical Sciences, their journal. But we've already discussed the ultra-processed food, so the rise in ultra-processed food, the lack of fiber in our diets, that's a separate thing. So that's like an environmental thing. On a physiological level, South Asian people are born with less muscle mass than Caucasian counterparts. So when we are born, if you put a Caucasian person and a South Asian person with the same BMI, same age, same weight, height, everything, you match them, the South Asian person has a lower muscle mass. The Bangladeshi people in particular, and again, no offense to any people from Bangladeshi heritage who are on this call, Bangladeshi people are shorter and they have even less muscle mass. Pakistanis, Indians, we're not so short, but we have less muscle mass. So glucose disposal occurs at the level of the muscle. So South Asian people are born with less muscle mass. They do not engage in resistance exercise, generally speaking. So resistance exercise is the type of exercise that tears down your muscles. We'll all know from medical, nursing, dental school that there's, type 1, type 2 muscle fibers, that you need your muscle fibers to grow through resistance exercise to act as a site of glucose disposal. So that's one. South Asian women, Pakistani women, again, no offense to anyone, I'm a Pakistani woman, are amongst some of the laziest members of society, and that has been statistically proven. This is not my opinion, this has been statistically proven, particularly in the UK. South Asian women are the laziest members of society who do absolutely no exercise. So that is part of it. That's the diet and lifestyle aspect and some of the physiology. The other thing that can happen in women in particular is there's a lot of epigenetics. So if you are born to a mother that has dysglycemia, so if you are in the uterus of a mother who has gestational diabetes, then that has a unfavorable effect on the pancreas of the developing fetus. And there is some evidence that the developing fetus attains less pancreatic mass, less beta cell mass, and that sets that fetus up for dysglycemia in later life. So it may be that we're seeing now a generation of people coming through who have had that epigenetic effect. It's incredibly, incredibly complex. There's kind of no one answer. And people just get very obsessed, or main to bahut chini, mujhe to meetha bahut pasand hai, isliye mujhe sugar hai. That's not true, right? It's much, much more complicated than that.
Wonderful. One more question, Dr. Rizvi. You mentioned that you have great interest in nutrition. What do you suggest for a healthy but filling snack for a working professional adult and children in today's lifestyle, especially in UK? Lots of patients ask about this.
Yeah, so a healthy, fulfilling snack, I'll tell you what I eat. I tend to have a bag of nuts in my drawer at work. So I have nuts, and I'll have a herbal tea. That's a great snack. Caffeine free. You can have coffee. Coffee is great, but try and avoid too much caffeine. So nuts, seeds. I try and avoid fruit. I have to say I don't eat a lot of fruit. Nuts and seeds, anything like vegetarian as well is a great snack. A low carb snack, other things if you don't want a vegetarian snack. So cream cheese with celery, that sort of thing, or some cured meat with celery. Cured meat is a little bit problematic, like salami, because it has quite a lot of saturated fat in it, but cured meat with some celery and cream cheese. Low carb snacks, there's lots of low carb snacks that you can find out there.
Okay, brilliant. And one more question from Dr. Kazim is, what do you see the future patients and their diabetes control with the advent of new drugs, GLP-1s, etc., and better access to insulin therapy versus promotion of fast food, delivery rates, etc.? Is patient control likely to get better or worse?
Yeah, it's not. That's a great question. It's not going to get better. I mean, I don't think it's going to get better soon. I think things will get a bit worse before they get better. There is a lobby for healthy eating. My problem with Deliveroo and Uber Eats is, I remember when I was a kid, if you wanted to get a takeaway, you'd have to get up, put your shoes on, put your coat on, go out, walk to the corner shop and get your takeaway and bring it home. Now people don't even need to move from their sofa, and they get their food delivered right to basically to their sofa. And then these foods have become more sophisticated, as I mentioned, with neuroscientist input. These foods are becoming addictive. We crave these foods, and there's a heterogeneous population, and some populations really become very overweight and obese when they consume these foods. So that is how Novo Nordisk have, I think, doubled their GDP. They doubled the GDP of Denmark from the release of Ozempic, because they are capitalizing on this obesity crisis. And one slide which I didn't share is the very strong relationship between obesity and diabetes. I'm sure you all know this, but your risk of diabetes increases dramatically as your BMI increases. So these two things are going hand in hand.
Okay, wonderful. One more thing mentioned by Sayed Jaffrey is that it's irrelevant or irrelevant to this talk, but have you seen an evidence of not accepting diagnosis of diabetes mellitus in certain ethnicity groups such as African descent? They take it as a very bad news if you...
Yeah, yes, I have. Yeah, I see it all the time. And that, for the patients I have seen, is usually around some sort of anxiety around insulin therapy, anxiety around kidney disease. A lot of people may have had, you know, a relative or family member with diabetes who didn't do well, who ended up on dialysis, or who died of a heart attack. And so there's a lot of, what's the word? Trauma or adverse experiences around diabetes. A lot of people carry that. And there's a much more increased risk of depression and anxiety in people around diabetes. You have to remember that people that get type 2 diabetes are generally not the wealthiest, most affluent members of society. They are generally the, you know, less well-off people of society. And often, unfortunately, those people have had some sort of, you know, adverse childhood event.
Okay. Thank you so much. And the last one is, please, can you share this PowerPoint with us, Dr. Rizvi? This will be on SIVU website that I have mentioned on the chat group. You can follow the SIVU group. And just again, we're going to mention Dr. Fareeha Rizvi's social medias. She's on social media, TikTok, Instagram, under, you can write this down, and we have written it on the chat group, at Diabetes Care with Dr. F. Rizvi. DIABETES, care with Dr. F. Rizvi. It's on the chat group as well. And on her website, fareeharizvi.com. It's with FAREEHARIZVI, Rizvi.com. It's on the chat. And you can follow it on SIVU series, which again, the link is on the chat group. And Dr. Fareeha Rizvi has put it once again for your disposals. So wonderful. Any other questions, or should we now come to the conclusion of thanking Dr. Fareeha Rizvi? Any more questions? Okay, so thank you once again, Dr. Fareeha Rizvi, for your time, dedication, and for delivering such an insightful and invaluable webinar on managing diabetes during Ramadan. Your expertise, practical advice, and thoughtful approach to patient care are deeply appreciated. We are truly grateful for the knowledge you've shared with us today, and may Allah give you jaza for doing it, especially in Ramadan with having a roza. And a big thank you to Imamia Medics International, IMI UK chapter, and Sadiq International Virtual University, SIVU, Dr. Shabeeh Zaidi, for organizing these valuable sessions and providing a platform for such an important discussion. Thank you all to the participants for joining us today. We have found these sessions very informative and helpful. And if you want to look at any other webinar series, please feel free to join the SIVU and IMI website, which the links will be attached on the group. As you can see, they are right there under the chat group. I'll copy it once again. It's sivualsadikani.com, and you can follow them on YouTube at Al Sadiq International Virtuos 2661. I'll copy this once again and put it here for your disposal. So thank you so much. There you go.
Bye. Thank you so much.
Thank you. We are going to close the session once everyone's taken the websites and addresses. Thank you, Dr.